My name's Devin Rubin. I'm a neurologist at Mayo Clinic in Jacksonville, Florida, and I'm so happy to be here with you this morning for this Lessons from the Lab live session. I don't know if you're familiar with Lessons from the Lab. This is an endeavor that the AANEM Education Committee began about 2 years ago. Has anyone heard of this? Are you familiar with it? Okay. I have no idea if people are listening and watching, but this was an idea that basically I thought of with the Education Committee to present a case. We all learn from each other and bring a guest, present a case that's unknown to that specialist or that physician, and just talk through how they would approach the case, how I would approach it, the similarities, the differences, the thought process of going through a case. And through the last 2 years of doing this, I've really enjoyed it. I've learned so much from my colleagues. I hope that people who are listening or watching it, it's on YouTube, the AANEM YouTube channel. It's on the AANEM podcast. If you don't want to sit for 45 minutes and watch it, you can listen on podcast. But my goal and our goal is hopefully that people enjoy it, have fun listening, and certainly learn something that helps you in your practice. So as we got traction, a little bit of traction on this, I thought last year, well, why not try to do a live session? We did 2 live ones in the past couple of years that were more like webinars. They were on Zoom, which is always hard to have interactivity, but those were fun. But we said, let's try this at the annual meeting. So you're at the very first truly live Lessons from the Lab. And I hope that it will be enjoyable, fun. I have no idea how this will go, so we'll have fun all together. Just a couple of points. What I plan to do is I'm going to present 2 cases over the hour and a half. I have 2 wonderful guests that are going to join me, and we'll learn from each other and we'll learn from you. I'd like this to be somewhat interactive. We're not going to call on anyone, but if you want to add in any of your thoughts or suggestions, please do that. This is going to be recorded. If the recording is good, it will probably be on the AANEM podcast. That's the intent. So if you don't consent to having your voice on a podcast, then don't say anything. If you do want to speak, if you don't mind coming up to the microphone, or you can shout out your thoughts and we'll just repeat them on our microphone. So with that, I want to welcome my colleagues and guests. We have 2 wonderful people, Ileana Howard from University of Washington and Mike Anderi from Michigan State University. Come on up here. I want to thank you both for participating. I know, I told them, I asked them, I invited them to participate. I said, this is the easiest talk you ever have to do. No preparation, you just have to show up on time. You don't know anything about the case, I'll take care of that, but you have to be up here and discuss a case that you don't know about. Now, Mike has a little bit of an advantage, right? Because you've done this before with me. Yeah. Yes. You remember that?
Barely.
Barely, yeah.
I was crying for 3 days after.
Yeah, so was I. I didn't understand a word he was saying, so if you listen to that one, has anyone listened to us, that episode? We had a bet.
We did.
We bet a beer.
Yes.
I don't remember who won the bet.
I won the bet.
He thinks he won the bet, but I don't think so. So we still haven't given each other the beer. We'll see if there's a bet this time.
Okay.
Yeah. And Ileana, it's your first time.
Yes.
I wouldn't say you're a novice, but you're first time here. So you excited?
I showed up. I'm on time. I think I'm already crushing it.
Yeah, you are. Yeah. That's the hardest part. So, yeah. So you guys having a good meeting? Is this your first session at the meeting that you've been to?
Yes.
Or first session you were at one?
I went to the Hot Pockets this morning, or the Hot Topics.
Hot Pockets?
I like to call it the
Oh, that's the restaurant down the street,
That's
right?
what I hear every
Yeah.
time I see Hot Topics. I think Hot Pockets.
Yeah. Did you learn anything?
It was a fantastic session. Yeah, it was really good. Did anybody else go to that session this morning? It was really good.
Yeah. I mean, that's as we all know, we learned so much at this meeting. This is my first session, but I learned something really important and something I was really proud of being in San Francisco. 2 days ago. I learned how to take a Waymo. Has anyone done that? Do you know what the Waymo is? That
Just
driverless.
downloaded the app.
You just downloaded the app. So,
Almost took one last night.
so my wife and I said, we've got to do this. We were really nervous, and we said, we've just got to do it. So we got the app, we got in the car. This is the driverless car, and we were happy. We got in it. We were successful. It was going, and I said, you can choose whatever music you want to put on. So I chose Lessons from the Lab podcast.
Naturally.
And the car started going around and around. It dropped us off in some area we didn't want to go. No, I didn't. We put on some better music than that. So, but if you haven't done it, it's really cool, and we survived, and it was a neat thing. So I did learn that, and I was proud to do something that was technologically advanced for even me. I was even thinking, I wonder if eventually we're going to have, that's a driverless car, we're going to have a providerless EMG. Some robot, something that's just putting the needles in, and AI is going to interpret all the data. Who knows in 20 years what it's going to be like. So anyway, do it. Do the
Waymo?
Yeah,
All right.
yeah.
All right.
All right, so let's go ahead and get into this. You guys ready? Everyone ready? So I'm going to present, again, 2 cases. We'll take about 45 minutes per case. And these are my disclosures. So the goal of this session is to talk about how we approach cases in the EMG lab, and hopefully we'll have some fun with this as well. So the first case was a woman I saw about a year ago. And she was an 82-year-old woman. You guys see that okay? Yep. Okay. I realize you won't be able to see the slides very well from there, but so she was an 82-year-old woman who was presented to our EMG lab for right upper extremity weakness. And her story was that in August of 24, she had an upper respiratory type of illness, a typical illness, nothing real unusual. And a few weeks later, she was exercising in the pool. She didn't have any problem before then. She was in a pool, which she typically does, and she pulled herself up on the diving board. And she says she always did this. This is nothing unusual for her. She didn't experience any pain with it. She didn't have any unusual positioning. She didn't fall doing this. And then a week after that, she noted some relatively quick onset of weakness in her right hand. And what she described is that the water would flow through her fingers when she was swimming. She had some difficulty closing her fingers, so the water was kind of going through it. And she noted that she had difficulty raising her wrist and fingers. No neck pain, no shoulder pain, no arm pain. She may have said she had a little bit of numbness in her hand, but that was temporary. That wasn't really a big problem. And she didn't really specify where the sensory symptoms were. And that continued for a while. She eventually saw physicians and was sent for an EMG lab. She thought there was a little bit of improvement, but she still had the difficulty closing her fingers. So that was the story. Any questions about that from anyone?
Did she have pain in her back? Did she have like a knife-like pain in her back?
So, and I'm going to repeat since we're the question. So is there pain in the back? No knife-like pain in the back. Why do you ask that?
Maybe brachial plexitis.
Okay, brachial plexitis. Yeah. Any other questions about the history? Anyone ever see any patient like this? It's kind of a weird story, isn't it? Yeah. What about you guys? Any questions or?
We're going to examine the patient, right?
Do you examine patients?
Occasionally.
Yeah. It's kind of important, yeah. But in terms of the history, that was pretty much it. I mean, she didn't, I don't think I have a slide here on past history, but her past medical history, there was really nothing significant. She didn't have diabetes, really no major systemic medical problems. So really nothing that stood out there.
And her walking is fine.
And her walking was fine, although we haven't examined her yet. So her swimming is fine except for her hand.
Okay.
Yeah. But her walking, she didn't have any complaints. So this was her exam. This is hard for you. I'll just describe it. This is using the manual muscle testing, the Mayo scale, which I know is kind of a unique scale. On our scale, our grading 0 is normal, -4 is paralyzed, so it's -1's 25% weak, and so forth. So basically, everything was fine except her right upper extremity. She had mild weakness in her triceps, her wrist flexors, her digit flexors, thenar, severe weakness in her hypothenar and interossei, so -3. She had some weakness in her flexor pollicis longus, flexor digitorum profundus, and her wrist extensors, her flexor carpi radialis was equivocally weak, and her flexor carpi ulnaris was moderately weak. Reflexes were, she had reduced Achilles reflexes, but in the arm they were okay, and her sensory exam objectively was normal. So, questions or questions about the exam? Her extensor muscles were weak, so her wrist extensors, here's her digit extensors, so about 50 to 75% weak in finger extensors. And her wrist extensors, her flexor carpi radialis was questionably weak. Her flexor carpi ulnaris was moderately weak.
So, going back to her history, Dr. Andre already asked about lower extremity weakness. I would be remiss. She gives a great history for neuralgic amyotrophy. So of course, with that history, that's the first thing that jumps up. However, I'd be remiss if I didn't ask her if she noticed any changes in swallowing or breathing or any dyspnea in the setting of painless weakness.
Okay, and if you ask, when you're asking that, in terms of neuralgic amyotrophy, or
No.
in terms of other?
No, and always keeping a wide index of suspicion for motor neuron disease in someone presenting with painless weakness.
Yeah, so there is painless weakness. Her sensory exam, she may have had a little sensory symptoms, but no major sensory symptoms. Yeah, and I guess getting back just to that question is, and I'll ask this for anyone, is there any value in asking about shortness of breath if you suspect neuralgic amyotrophy? Anyone ever ask that if you have a patient you think has Parsonage Turner and ask, do you have shortness of breath when you're laying down? Do you ever ask that?
Heck, yeah.
Yeah. Ask it to anyone. Why would you ask in that
Well,
situation?
the phrenic nerve is involved in, I don't know what the percentage is, but the phrenic nerve is involved in a significant percentage of cases.
Yeah. So, I mean, I don't think, in my experience, it's not common, but more often than not, we see a patient that presents with shortness of breath. They come to us, they don't have the arm symptoms, and that's probably a manifestation of neuralgic amyotrophy involving primarily the phrenic. So, I think there's value in that. Yeah. Yes?
Did you do more of a physical exam than this, or is this all we're going to know of for physical exam?
Did I do more of a physical exam than this? Well, I can't remember yesterday, so I can't remember all the way back. What else would you have done? Coordination?
Tandem gait.
Okay. I didn't do tandem gait, so to be honest, this patient was laying in the bed in the EMG lab. So I was not seeing this patient in clinic. So I don't usually get the patient up to walk unless it's really important. I didn't do any finger to nose or heel to shin on that. Would you have done that? Or why are you thinking that?
What's jumping out to me is I can't localize that weakness to one particular place, and she did have that weird thing with the diving board, and just thinking about her spinal cord
Yeah.
and whether there could be something there. So, and then also just thinking about central nervous system stuff. Sometimes people just are weak because they can't. It's not peripheral at all.
Yeah.
So just having a little information about her ability to use the hand.
Yeah. So the point is, just to repeat, maybe you think about a spinal cord issue, think about a central problem. Maybe she had a stroke. Have you guys ever seen a patient in the EMG lab that had a stroke?
Oh, yeah.
Yeah.
Oh, yeah.
Yeah.
So I was really glad to see that you did a Babinski, because if you didn't, I was going to go after it. In my lab, I will argue with the residents, do a Babinski on every patient, even if they have an amputation of the leg.
So if the patient's sent for carpal tunnel syndrome, they have numbness in these three fingers at night, they're shaking their hand, that's the only problem they have, you do a Babinski.
Absolutely.
Yeah? Those poor patients. Yeah.
Well, you know, but I might not do a sensory exam.
You might not do a sensory exam?
Yep. I mean, everybody gets to do what they want, but I can't tell you how many people I've seen with arm symptoms who have upgoing toes and end
Yeah.
up with cervical stenosis.
Yeah.
So I'm with you on this. Oh, yeah.
What about you? Do you do a Babinski on every patient in the EMG lab?
I mean, I think it's important to interrogate the integrity of the peripheral nervous system. So I would say I'm Team Babinski.
Okay.
Yeah, okay.
I might do it more than I should. We could debate that, but I definitely don't do it less than I should.
Okay.
Because I do it on every
Okay.
patient.
You said every, so we can have,
Virtually
this could be our
every.
bet. You heard it, he said every.
I did.
No.
I did.
I think the point is well taken. You know, we do see patients that come because there's a question of a peripheral problem and it's central. I remember some patients years ago that had a big glioma. And, you know, they came in and we examined them, they're sent for an EMG because non-neurologists, non-physiatrists are not thinking, you know, they don't really do a good exam, and they were sent for the EMG, and it was very clear, not just with Babinski, but the exam was hyperreflexia, spasticity unilaterally. So obviously, this is an obvious point, but an important point that we should always be performing a good exam and repeating the exam. You know, I don't know if you guys, if you have a patient sent by a colleague, do you just trust their exam or do you always repeat it? Like for the.
Well, I repeat it.
Yeah,
Oh,
yeah.
yeah.
I mean, I think we all would. So people might miss things. I've certainly missed things on exam. So I think it's important to trust your own examination.
Yeah.
Yeah.
Did you want to say something?
I just tell the residents, if you're gonna check reflexes, and you gotta do Hoffman's, Clonus, and Babinski, it comes together, because you will kick yourself in the butt later that you.
Yeah,
They're all the same things.
yeah, yeah. Right, good. Yes?
Did you check for scapular vein?
On this patient, I don't know that I checked for it, but that's a good point. I think, especially if you're thinking parsonage Turner, and you know, patients aren't always going to complain, right, that their scapula's popping out. But yeah, absolutely. When I'm thinking about it, I you know, sit the patient up in bed and hold their arms up and check for all that. Yeah, I don't remember if I did in this patient or not.
Good point. I got one more.
Yeah.
For physical exam, you got somebody here with arm symptoms, I would do neck range of motion and probably shoulder range of motion. But there's, maybe I definitely do more, because I will probably bill an E&M and want to examine the patient. But neck range of motion and Sperling's,
Yeah.
almost surely I would do. I don't do it on every patient.
Right, yeah. I don't know how to do the musculoskeletal exam. I'm a neurologist, so. No,
But I don't say that about Babinski, and I'm not a
I know.
neurologist.
See, that's why I learn. I learn from everyone, so. So, okay, let's just talk about, let's get into here for a moment, what are possible, I don't know, when you're kind of thinking through the case, you know, we've talked about the exam and the history, and then the next thing, in my mind, the way I think about it, is not jumping to the diagnosis, but the localization, right? So we think, where is the localization? We've talked a little bit about this in some of the comments, but thoughts about where this may be localized, or can we localize it to a single area of the peripheral nervous system? Any thoughts?
A lot of concern for the lower brachial plexus, lower trunk brachial plexus.
Okay, so lower trunk, so brachial plexus, lower trunk, okay. And anything else that this could be?
I'll
What do
go
you guys
C8, T1, maybe C7. So
Okay, so root.
But it looks to be two roots probably, but,
Two roots. Why would you say two roots?
well, your finger extensors don't have a lot of T1, so could C8 be in there and just call it C8? It's plausible, but, and then the hypothenar, many people think is more, we could discuss this, is more T1, and that's really weak, right, on your exam.
Yeah.
So that makes me think that's hard to put into one root, causing that much trouble without a numb little finger.
Yeah.
I got C8 would have
So
to be
you
totally
think
trash.
you think hypothenar is more T1 than C8?
Yes.
Yeah. Do you agree with him or?
no opinion on that.
No opinion? How many agree with Dr. Anderi? Hypothenar is more C8, it's more T1. You said more T1?
Yeah, more T1.
How many disagree?
I believe I'm an outlier.
I don't know. I don't know if
And
there's
I
an
think
answer
the
to
data
it.
for what I said is weak.
Yeah.
But it's anecdotal.
I think there's data, and this is more on neurogenic thoracic outlet syndrome, that the thenar is more T1. Thenar.
Oh,
If
did
you-
I say hypothenar? My bad.
You meant thenar.
I meant thenar, and I misread it. Actually, I misread it. on
Okay,
there.
good. So we agree.
Okay,
Yeah,
my
yeah,
bad. I
yeah.
apologize.
Yeah,
Thank
so
you.
there's good data. This is sort of an
My
aside.
first
but
mistake so far.
You caught it. You caught it. You're still winning the bet. Yeah, yeah. There is good data, and I think it's a good clinical point. It's a good electrodiagnostic point, particularly in neurogenic thoracic outlet syndrome, that more often than not, the median motor response to the thenar muscle is affected more than the ulnar ADM response. And there's been some nice papers showing that. So, yeah.
How often do you sort of think about prefix, postfix, like everybody's like very normal variance of levels?
So how often do I think of prefix and postfix? I always think about it. The percentage is, they say, is about 5% or so, but I think about it more when things aren't making sense, right? So if, I see a patient that has what looks like a C8 root problem, and I see imaging that shows a big disc at C7 or T1, then I might think about that. Yeah, we don't know, right? There's no way to know that. Okay, so we've said root, we've said lower trunk plexus, C7, 8, T1 roots. Could this be anything else? You have any other?
2 chords,
2 chords, okay. Which chords?
probably posterior and medial.
Okay, yeah. Could it be individual nerves? Could this just be multiple nerves?
Yes.
Yeah? Everyone agree? Does the fact, I'm going to pick something out here, and it may be hard for you guys to see, but does the fact that the flexor carpi, I'm so sorry, this should be extensor. This should be extensor carpi, not flexor. The extensor carpi radialis is pretty normal, and the extensor carpi ulnaris is severely weak. Does that bother you or make you think? Yeah?
It does me. Yeah, so if you take somebody with a C6 quadriplegic, and their C6 is good, and their C7 is weak, their triceps is weak, then when you ask them to extend their wrist, they will radially deviate. So I'm assuming that's what, you saw something here, because in my view, it's really hard to tell the difference between ECR and ECU on strength. But if you ask them to extend and they radially or ulnarly deviate, they might be more likely to have a C6 lesion.
Yeah.
You agree with
Yeah,
that?
I agree. I
Okay.
agree. I don't, do you, yeah.
Do you use EIP strength in this situation? Be helpful?
Yeah, I do. I don't know if I put it on here, but it was similar to digit extensors. Yeah. Yeah.
And thumb extension too, I would agree.
Yeah. And I think it's a good point. I mean, if you think about it, and maybe I'll ask you, when you're seeing a patient and that has, arm pain, non-specific arm pain, and you're testing their strength, how do you test their wrist extensors? What's your typical, show us how you would test wrist extensors.
Make a fist. So I try to keep their finger extensors out of it, cock it up, and then I will break it. So I will, if she's like
Yeah.
a football player, I'll do that, or
Yeah.
I'll put it on there and I'll lean my body weight into it.
Yeah.
So in my view, if you don't
Yeah.
overcome the muscle and break it, you don't know how strong it is, and you don't want to know.
Do you ever do this on the wrist like that?
Not yet. Okay. Come on over.
Was that the diving board maneuver that got her into this situation?
I don't know. I don't know. Oh, I
was
got
she-
you.
yeah.
No, I have no
Was she-
idea.
no.
The etiology of this, I'm not going
Is
yet.
that a
I think-
thing? No,
I think
okay,
she
okay,
I
it's
think
a new
she told
thing now.
you that. Oh, okay. Sorry.
But is that how you do a wrist extensor exam similarly?
Yeah, absolutely isolating the joint
Yeah.
above and below to,
Yes, and I put my hand above and
Leveraging, yeah,
below,
yeah.
and I went more distal to get a, more,
Yeah.
leverage.
leverage.
But I think the point of that, and this I think is something we teach our residents and fellows, is you're testing two different extensor muscles when you do that. To your point, you made that point. You're testing ECR and ECU, and they have different root innervations. So I always think of ECU as C7-8 and ECR as 6-7-ish. You know, there's overlap, of course, but you can, I've seen people miss weakness of one of those muscles because you're just doing test and extension this way, rather than isolating, as you're saying, Mike, you know, extension and radial deviation and extension and ulnar deviation. And I think that's a really practical clinical pearl if you're trying to tease out possible root localizations. You don't always find it because sometimes they're not that weak, but I think many people, probably about most of us, if we're just doing a general screen, we just have them extend their wrist in neutral position. Yeah.
And then your finger flexors, if I can comment on that. You did finger flexion, so the question I would ask then, I don't always do this, but I frequently do this, is it flexor digitorum profundus, which can have AIN branch, or flexor pollicis longus, or is it the flexor digitorum superficialis, which is harder to test?
Yeah.
To test the FDS, you have to do that, and that's a median nerve, not AIN.
Right.
In this case, what I have done that, I might have, because if it's possible NA, as you know, it frequently gets the anterior interosseous nerve.
Yeah, yeah, and I agree. Sometimes I do. If I'm more concerned about certain nerves, then I'll be a little more deliberate in what I test. I think the other point, and we're going to get into what we would do in the lab, but the other point that would be sort of a question or a clue with this discrepancy is I was thinking about individual nerves, it'd be a little unusual for the radial nerve to be affected. Not that it can't be at one spot, you know, with in between the branches of two of the branches, but it'd be a little unusual to have one of those muscles pretty good and the other very weak. So kind of, to me, pushing it away from multiple individual nerves, but we still don't know. Yeah. Any other thoughts, just in terms of localization? Okay, so let's get into how we would approach this in the lab. And you know, this is where I always find it interesting in these interviews and discussing it with others, because you know, there's different routes that we can take. So what would people do? What would you start off doing in the EMG lab? What would someone do? You can just shout it out. So you start with nerve conductions? Yeah. Would everyone do that? Yeah, would you guys?
I might go right to needles. If I don't have residents with me and I'm by myself, I might go right to needles. When I trained back last century when we didn't have digital machines, with George Kraft and them, we probably started with needles 2/3 of the time.
Mm-hmm. Okay.
So I
And
kind of.
I don't think there's anything wrong, you know, there's nothing wrong with, you know, there's not a set right way of approaching a patient. I guess I would ask you and argue, I mean, so what's the benefit in your mind of starting with the needle exam versus the nerve conductions?
So one of the things is, would the needle exam change my nerve conductions? Okay, and it might. Like if I find fibs or no fibrillations anywhere versus a lot of fibrillations, or fibrillations in 3 nerves, and it makes sense, then I can maybe focus plus it's axonal and not demyelinating. At least there's axonal and you know, it might be both, but. So it will almost surely change my nerve conductions. And, you know, that old Sutton's Law, where's the money? You know, why do you rob banks? Because that's where the money is. So
Right.
in this case, in my view, the best part of the test is going to probably be the needle EMG.
Do you think that in this case you could only do the needle EMG?
No.
No? What if you find fibs in all the muscles that are examined, you know, fibs in all these weak muscles, dense fibs, and big motor units? So you know it's neurogenic, and you have, in all the other muscles that are normal, strength-wise is normal. The
I'm
needle
still going to
exam's
do
not.
nerve conductions.
Yeah.
Go
I
ahead.
mean, you haven't ruled out the other things on your differential, which is equally important to cinching the diagnosis.
Yeah, yeah. So how would nerve conduction, so our differentials, multiple mononeuropathies, multiple roots, or part of the plexus, right? That's kind of what we're all thinking about. So how would the nerve conductions help separate that out in your mind?
The sensories are going to be pretty important to differentiate preganglionic versus postganglionic.
Yeah, yeah. So you might
Sensory snap amplitude, right?
snap
What was that?
amplitude, yeah, yeah.
And they probably have carpal tunnel too, we just don't know it.
Yeah, yeah. Well, of course, the patients don't read the book and they don't come with just one thing. So, right. Okay. So would most people start with nerve conductions? Yeah. And so someone said ulnar motor. Anyone start with something else? If you start with nerve conductions, do you have a protocol or no?
No.
You pick whatever you feel like?
Depending on the day.
Yeah.
Depending on the day? Okay. Okay.
Depends on the patient too. If
Dep-
she's super anxious, I might start with sensories.
Yeah.
Because it's less electrical stim, right? And I never start with needle on an anxious patient, right? I always start with the nerve conduction.
Yeah.
Gotta read the room. Right?
Yeah, you don't want to
Yeah,
say, I'm going to
good
put this
point.
in your muscle here, here's the big needle I'm going to do. But yeah, no, I think that's a great point, that you don't know what you're going to get, right? Most patients, I think in our experience, is that they'll mostly tolerate it, but you don't know. So where's the money? What do you, if you're only going to get one conduction, what do you want to get? And maybe I'll ask that here. So if, let's say you have the patient says, I'm giving you one nerve conduction, so pick what you want.
I love this question.
That's fun.
Yeah. So,
Do I
so
do
what
this
would
to you
people
guys,
do?
residents?
Let's
Oh, yeah.
ask. What would people do? Ulnar what? Well, ulnar. Yeah. Ulnar's weak, so do ulnar motor. Someone said ulnar sensory. Could argue for radial sensory. Anyone for something else?
I don't know what ulnar sensory or ulnar motor, because I'm still worried about a demyelinating process, and I think the ulnar motor gives us more, and I can get an F wave off it.
Okay.
Cheater F wave. So I'm probably going with the ulnar motor. But
Okay.
the ulnar D5 is a tough one to argue against.
Okay.
The sensory.
Yeah,
With the little
right,
finger.
right.
Yeah.
Okay. Eliana,
Jeez.
you get one.
I never just get one because
Because
just
you're so
gonna-
good.
No,
You're
I
so
am
good.
I
I know.
we're gonna be driving just
Yeah,
fine.
losers
so,
like me, we gotta put up with just one sometimes.
Well, maybe your technique's much better than
I didn't
his,
say
Yeah.
I didn't say that, but I would lean towards the ulnar sensory. I think would be a nice place to start. It would be really informative.
Yeah. Okay.
Because if it's
And-
small, it changes your diagnosis, or absent, right?
Yeah.
I mean, it tells you postganglionic and it's convincing.
What if they have an ulnar neuropathy too?
Well,
Subclinical ulnar neuropathy.
Right, but it's hard. But
Okay.
It's not root,
Yeah.
right?
Any others? All right, let's just go through some of the data that we do. And I think, again, these are great points. There's no set way of doing that. At Mayo, we're a little more protocolized, which I don't love that term. And I always, when I'm teaching our techs, I say, yes, we have these algorithms of kind of how we think. And partially that's because the tech's going first, so they're kind of going through this algorithm. But I always stress to them that an algorithm is not set. It's what are you thinking? What's most important? But in our lab, and someone like this, we would usually start with a median motor. So I don't know if you guys can see it. And I'm not going to belabor a lot of these here, but what's nice, and it's hard to see the numbers, but green is good on our machine, so green's within normal values. And median motor, APB, wrist and elbow is fine,
As expected.
as expected, yeah. And we did F waves, yeah, so there is a value in F waves. I agree with you here. You don't know if there's some proximal demyelination, and these were within our normal values for F estimate. So then we did ulnar motor, and we did a standard motor study, but we also recorded, in this case, from the FDI as well as the ADM. So the top is ADM, the bottom is first dorsal interosseous recording, 2-channel. And this is recording from wrist, below elbow, and above elbow. And basically, they're really, the ADM's within normal values. In our lab, it should be over 6. So it's just slightly over 6 millivolts, 6.3. Our FDI is a little bit low for our lab, the
So
amplitude.
when you do the FDI, where do you put your reference?
We put our reference down here at the base.
Okay, so I put it just a little more distal to that. So my understanding is that the amplitude is not reliable on that, and you have to be very careful.
Yeah. And I think that there is a paper that just came out on that in Muscle and Nerve, or is coming out, or I just read something about that. Were you involved in that?
No, I wasn't,
No, no.
Dimitri taught me this a while ago, that if you don't have the standardized, like where you put your electrodes, and especially for that muscle, that your amplitudes are, because I routinely do that, and I will get a 2 millivolt response amplitude, and it's normal. I will consider that normal.
Yeah.
But I don't make a call, but I do make a call based on either conduction block or slowing.
Right. And I think that's a good point, and I think it gets to the point of your technique should mimic your reference values should be, that you use should be based on the technique that the reference values were
That's a great
obtained.
point. Yeah.
Right? So our reference values were obtained with E1 here and E2 at the base of the first metacarpal bone. And so for that reference value, that's a little bit low.
Okay.
But to your point, if you move that, remember, we're not going to get into this. We could do a lessons from the lab for 4 hours, but these are great points. But remember, the E2 is really important. It makes up a component of the CMAP. In fact, when you do your tibial motor study, the E2 makes up most of that waveform, the pickup of the E2. So you're exactly right. It depends. If you move that around, you're going to get different amplitudes. Yeah.
And it just highlights one of the reasons I don't like the colors. It's almost like a Stroop test. Because really, like the amplitude drops 0.1 millivolt between the below elbow and the elbow, but that red makes it highlight. I think you have to be cautious not to overinterpret the data.
Yeah. And I think to that point, the opposite point is that just because something's green doesn't mean it's normal for that patient.
True.
Right? We don't know what's normal for that patient. We have our normative data for nerve conductions are horrible. Most of us use very set data regardless of the patient's age. So, that needs to be redone and revisited, and I know some people are doing that. So, and
In this circumstance with a unilateral problem, a normal side to work with, could you not compare with the other side?
yeah, good point. So would you compare to the other side, would you? I would too. I agree completely. Yeah, we didn't get to that point yet, but you're right. That's when we're talking about reference values. If it's a unilateral problem, the best reference value to compare to is the normal side in that patient. So,
All right, can you go back to your F-wave slide, please? So your F-waves look really normal there, right? 27?
yep.
So in our lab, we don't reshock them 8 times for something we don't need to. So go back to your slide just before that. Now, see that top one? If you change your sweep speed and increase your gain, the F-wave is over in the table there.
Yep.
And you can find it.
Yep.
And you could look at usually 2 or 3, depending on how your machine stores stuff. And if they're really normal, I won't do a separate setup for the F-wave, because you can't fake normal. So if they're normal, move on. Saves you time for those of us who don't want to torture our patients.
Yeah, but you stamp on their wrist when you're testing their strength. So, yeah.
Well, there's that.
But since you bring up the F wave, what are you looking at to see if it's normal?
Well, I'm going to do penetrance and latency, and do the min to max. Boy, then you have to do it the way you said.
So do you just look at minimum latency? You have an absolute value if it's less than a certain value?
Yes. If I'm doing cheater, if they're normal and I've got 2 or 3 there and I can tell, and I can get penetrance from the elbow too, because So if the penetrance, I got 4 at least F waves, and I
Yeah.
haven't had to look for them, then I'll say my penetrance is normal and my latency is normal and move on.
So if your absolute, I'm going to play this argument, if
Sure.
your absolute latency is prolonged,
Oh, you got to redo it.
let's say you redo it and it's prolonged, how does that help you in terms of localization? So let's say this F wave was,
With
what do you use,
velocities like
32?
that, with velocities like that, I would say it's probably proximal demyelination, probably. And
Yeah.
I don't calculate the axillary loop anymore. I did that for a while.
Yeah.
What do you do?
So I think that's sort of the struggle with these F waves. For us, if you're using an absolute value, it doesn't really localize. I mean, I agree with your point. If you, just going back, if you have a really nice conduction velocity between wrist and elbow, really good, and then it's slow, then it'd be suspicious for a more proximal slowing. We use an F estimate, so we always compare to an estimate, right? So we estimate based on the conduction velocity in the forearm and the distal latency, how long it should take to go up to the spinal cord and back, and use it to that, to compare it to that. So if it's prolonged compared to the estimate, that indicates the slowing's got to be more proximally.
Okay.
Because if you have just a bad median neuropathy at the wrist and you use an absolute value, it might be prolonged.
It's not as good, I would agree.
Yeah.
You do it better than I do, I hate to say that. Now,
Well,
do
it's
you
not-
measure
yeah.
the length of the arm?
Yes, we measure, in our lab, we measure from the distal site of stimulation to the sternoclavicular joint, and our reference in the leg is from distal site of stimulation to the xiphoid.
So I was doing that for a while, and it just took too long, and I'm lazy.
Well, I can't fix that. Yeah,
Efficient.
yeah.
You're
What do you do?
efficient.
Well, right, we
Do
can
you-
argue that,
What do you do? How do
No,
you,
just use
you
one
don't-
height, yeah.
just height and absolute value? Yeah, yeah. Okay, good. Any questions about that? Yeah.
At the very end of this case, when we get the answer, can we look back and see if the F waves added anything
Yeah,
to the case?
sure.
I'm just curious if they're even worth.
Yeah.
Yeah. To me, I think it's important from a rule out,
I will say,
but probably will not add in this case. I would agree.
I will say, I've been trying to rename F waves as, instead of standing for foot, standing for forget about them.
Futile?
Because, futile. Yeah, so to me, we've gone away in our lab, and so if someone just has classic radicular symptoms, so arm pain, neck pain, back pain, leg pain, we've stopped doing F waves because we haven't found them to be very useful, and I'm cautious about making a diagnosis simply based, if the only finding is a slightly prolonged F wave, I'm very cautious about overdiagnosing. We do them in patients sent for a polyneuropathy, so numbness in both of their feet, because we don't know if that numbness in both feet that's symmetric is a polyradiculopathy, a CIDP with proximal demyelination. So we do F waves in those situations to look for that proximal demyelination. But if it's unilateral, if it's, if we're not suspecting a possible demyelinating proximal problem, then we don't do them. In this case, I think it's very reasonable because it's an odd case, right? We don't really know exactly what's going on, and we have distal CMAPs that are actually not too bad. So, yeah.
What made you add on FDA study on this case?
I think in this case, it was that I believe that muscle seemed a bit weaker, and we were, some people argue you might, in ulnar neuropathy, we didn't think this patient had ulnar neuropathy, but the FDI may be more sensitive, looking for some involvement. Yeah,
I totally agree with that, by the way. We do the FDI a lot.
yeah. Okay, so that's what we have. We did sensories, so this is the ulnar antidromic to the digit 5. So we in our lab, we stimulate wrist and we do an elbow to get a conduction velocity across the elbow. And our normal value is over 15 at the wrist. I'm sorry, over 10, so it's well within normal values. So I think some of you said you would do that. Are we sure, would you say this is definitely normal?
What does the other side look like?
What does the other side look like? Yeah, so to Jeremy's point, you don't know. This is an 80-year-old, if you had to bet, a 30 microvolt and an
It's
83-year-old.
impressive, but she's an impressive 80-year-old.
She's pulling herself on diving boards, so yeah, I know. So it could be
What kind of
120.
dive was she doing?
Yeah, she was doing flips and, so 30.
Yeah, I would agree this is normal, sorry.
Yeah. We did median antidromic as well, thinking, we weren't too concerned about that, but again, another sensor nerve. She was letting us do more than one nerve, and that's normal. And then this is a little harder to see, but we did do the other side. So her other ulnar amplitude was 28, so almost identical. So would anyone do anything else? So we have normal sensories, we have pretty normal motors, FDI borderline low. Radial sensory? Yeah. So she has weakness in the radial. What would you be thinking in doing that? What would you're doing it because you're thinking of possible radial nerve or just part of the plexus or?
I'm doing it to try and reinforce my feeling that this is actually a purely motor phenomenon.
Yeah, okay.
Sensory symptoms as well.
So, yeah, so just making sure that it's a purely motor. So we did do that. So here's the radial sensory, and they're about equal 21, 23. And then we also did, no one has said this yet, but we did the medial anabrachial cutaneous or medial cutaneous nerve of the forearm, whatever you want to call it.
The MAC.
The MAC, I call it MAC. If you ask Strakowski, he'll get mad at you for saying that. But that's, I thought that was an important one.
Agreed.
I would.
Yeah, would you have done that? Yeah. Yeah, because this is someone said, I think lower trunk, medial cord, and this may be a more sensitive nerve for lower trunk in some cases than the ulnar antidromic, the ulnar to the fifth. Not always, but it gives you another nerve that's coming off of the lower trunk. But those were symmetric. Okay, now what?
If it's weak, poke it.
Poke it, okay. So tell me, we're not gonna go muscle by muscle here, but I'm just curious, your thought process, both of yours, what would you be planning to examine? I know it depends on what you find, but kind of what would you go into this study thinking you're gonna stick?
Well, I would base on the exam. I'd be poking muscles that were weak on exam. I'd be sure to include paraspinals now that we have normal sensories to adapt the test to the findings as we go along.
Mm-hmm, okay,
I'm gonna do normal and abnormal. I'm probably gonna do 8 to 10 muscles,
Okay.
okay? Probably, including the deltoid, bicep, triceps, cervical paraspinals. I'm probably gonna add the EI, extensor indices, and pronator quadratus. And I'm gonna recruit a good chunk of these muscles.
okay,
And I'm gonna probably do the other side, some muscles on the other side that were abnormal. If they're abnormal on the right, then I would pick some on the left looking for NA, if it's NA, sometimes you can find unsuspected abnormalities on the other side.
yeah, okay.
Remind me how long after the onset we're actually seeing this?
Yeah, this was a
forgot to ask
while.
that.
How long after the onset? It was
Almost a year.
several, almost a year. I mean, so it had been a while. Yeah. Took her a while to get in, probably.
Mayo Clinic.
Yeah,
long
I
line
know,
of
I
people wanna
know.
see
Our EMG
you.
lab's so busy. All right. We did do the ulnar motor on the other side here, and it was a little bit higher. And we did a radial motor too, looking for conduction block, and those actually were okay. Amplitude is a little low. So this is the table, and just to summarize, I know it's hard to see, but she had fibrillation potentials and long duration motor unit potentials with some with reduced recruitment in the APB, first dorsal interosseous, EIP, flexor carpi ulnaris, and triceps were long also. The pronator teres, biceps, deltoid were normal, and the paraspinals were normal. C8 paraspinals, and T1 was done, C8, T1. Triceps was not normal. It did not have fibrillations, but it had long duration, 2+ long duration motor unit potentials. So what do you do with this?
MRI of her neck.
MRI of the neck, okay. what's going through your mind here? Anyone? This is one of those where you say, well, the patient, here's the textbook. You need to read this. They didn't read the textbook, right? What do you think?
Well, I think it's exon loss. This still, in my view, fits for NA, less likely radiculopathy. It's getting better, okay, based on the polyphasics that the nerve is sprouting at least locally, and that clinically she was a little better, if I read that you could get some finger
Yeah.
flexion. And so you can make a case for the MRI of the neck, or the plexus, or nothing. I mean,
Yeah, I mean, she didn't. I mean, if it didn't bother her, she wouldn't be getting her EMG. So she's still bothered by it.
okay. Why is she because she's weak?
Because I remember that she was bothered
okay.
because when she swims, she can't close her fingers.
Okay.
Really, that was her
Okay.
main concern. It wasn't.
Wow, that's unusual.
It was, yeah. That was important to her. But going back, what do you think the localization could be here? So that, we're so focused on let's localize, and as you know, we can't always localize things, but that always bothers me when I can't localize it. So what are the possibilities in this situation? Does anyone think that this is root? Yeah, some heads, yeah.
It could be.
Could be root. How can it be root?
Paraspinals are just normal, and they rehealed and sprouted.
Okay, so maybe there's been
Or a false
reinnervation.
negative, sampling error.
Yeah.
Lousy electromyographer.
Yeah, that's usually what it is with me. But I don't know if you encounter this or if anyone does, and it happens to me in the lumbar paraspinals where I see patients that have a classic L5 or DIC and changes in all the L5 muscles, and I go to the L5 paraspinals and I can't find a darn fib. I can't find changes. And I angle the needle up, I stick a couple spots, and I just can't find it. Does that ever happen to you?
Every week.
I can't stand that. It bothers me. And
I get it.
And I do think it may be, I hate to say it, but it could be where's the needle? You don't know exactly where the L5 paraspinals. There's some overlap of the myotomes. There's good data that, particularly in the neck, where you think the C7 paraspinals are, actually part of that is innervated from a couple levels higher or lower. So I think that's where things like paraspinal mapping and sticking multiple times can be really helpful when you don't find it.
In Northern California, a lot of times they already have the MRI by the time they're coming for the EMG, because there's such a long wait for EMGs. And on the EMG, I call it the pork chop effect, where it's like the gristle. You ever look at the MRI of these people that you would expect to find fibs in their paraspinals, but then you look at their MRI and it's completely atrophied. They just don't have, they're little old ladies with no paraspinal muscles. So your chance of your needle actually getting to muscle fiber, you might be getting silence and thinking, oh great, their muscle's not denervated, but in fact you're just getting scar tissue or gristle.
Yeah.
It's the
yeah.
patient's fault.
We can always blame the patient.
We're fine.
Yeah, I think the other thing is, separate from that, is sometimes the changes are way down in the deeper levels of the paraspinals. And I know some of us, and if there's residents in here and you're learning, I think sometimes you guys are a little cautious about putting the needle deep, and even we are, we don't want to put the needle all the way down to the lamina, but sometimes you have to get to the deeper levels to start to see those changes. So, I don't know, do you find that too?
Yeah,
sometimes you're like,
Yeah.
gosh, I'm going really deep, the needle's buried in some of these big necks, and then you find it.
Yeah. And I agree with you, looking around a lot, but getting relaxation of that muscle is brutal, and
Yeah.
impossible in some patients. So then you got to live with a
Yeah.
negative study. At least I do.
Could this still be plexus? Yeah?
Yeah. Why couldn't this be lower trunk, primarily?
Well, that's what I'm asking.
Oh,
Yeah.
to me, it looks like it could be lower trunk still.
I mean, don't you have to have sensory abnormalities to show that it's postganglionic?
If it's a mass, yes. If it's NA, no.
Okay. So if it's NA, how do you know that's not just at
Neuralgic
the
amyotrophy.
right? How do you know that's not just at the root?
Well, you don't. Okay, or you get an MRI of the plexus and look for the hourglass, MRI changes. But
Yeah.
I would argue you don't know. It's
Yeah.
very difficult to know.
Right. Right. I mean, I think in this case, I agree. I mean, do you think this still could be plexus or still
Yeah,
hard to
yeah,
know?
I'm comfortable with the discomfort.
Yeah, comfort. You have to be that. You know, if we go into every EMG thinking we know it all, then you're missing things. You know, you're not being honest with yourself. And you know, it would bother me to think that this is plexus. I get the NA. You know, NA, neuralgic amyotrophy typically affects, at least objectively affects the motor nerves. And there's good data, good studies showing while patients may have sensory symptoms, the sensory nerve conduction studies are not often seen. Abnormalities not as much. But I would be bothered by the severity of the motor involvement electrophysiologically without any abnormality on the sensory to say that this confidently that this is plexus. So, yes. Yeah, you could do an ultrasound and look at the trunks, and that's where Dr. Bland would do that. Yeah. So, but yeah, you could look at the trunks. You could look for enlargement. You could look at the roots too. You could see is there enlargement of the roots. You could look for possible hourglass signs and things like that. Good. So, how many of you would do an MRI? Oh,
Think about on the map that it was normal, right? How do you look at it? If it was NA, then that would be okay. That the medial antebrachial is normal.
I'm not sure I understand the question, sorry.
You were just differentiating that it could be brachial plexus, but all the sensories are normal. So I just wanted to hear that again.
Yeah. So in the way I understand NA, if it's going to be autoimmune, I don't know about the twisting part of it, but that it affects the motor selectively. So the way, in my stupid mind, I think of it as the antibodies are going after the motor myelin and then the axons and leaving the sensory alone for reasons I don't understand. What,
yeah.
attack that.
No, I agree. I think, but you know, again, the thing that bothers me is when patients, not this patient, but patients that have the weakness, and if they have significant sensory symptoms or sensory loss, if it's postganglionic, you should see sensory nerve abnormalities, right?
I
But I
agree.
agree that the inflammatory process may cause pain, may cause a little bit of sensory symptoms, but they may not have objective sensory nerve deterioration. Yeah.
And frequently, the pain that this is the way I interpret it, they are C fibers and A delta. They're not usually in the skin. They're not usually numbness, although they have pain in their shoulder and neck or arm, but it's more of a sclerotomal pain, in my opinion, than a dermatomal pain, which is in the skin.
Yeah.
Derm being
Yeah.
skin.
And much of that pain is, you know, up in the shoulder area. But here's a challenge. I'll challenge you. I'll challenge you both.
All right.
This patient had absolutely no pain.
I know, I saw that.
Well, when she was a kid, she might have had pain, but not during this episode. She had no pain at all. No neck pain, no shoulder pain. So could that be?
It's an atypical presentation. I mean, that's where I'm going.
Yeah.
Okay. Yeah. Oh, yeah.
Okay.
But that doesn't get better, and that hurts,
Yeah.
right?
And it came on.
those snaps got to be small with a Pancoast.
And it came on pretty quickly, too.
That's
I mean,
true.
it's a
Good
good
point.
point. Yeah, you always think
Excellent
of something structural. You could say, could this be thoracic outlet, neurogenic thoracic outlet syndrome? But it came on pretty quickly, very, very quickly, over a week or so. Yeah.
So let's say this is an atypical inclusion body myositis, IBM. You got kind of painless weakness.
You're going way out there now.
I know, well,
Yeah.
I am. But you didn't look in the other side to see if there's fibs over there or the leg, and maybe she just, it's going to be atypical, we agree, going almost zebra, or rare zebra. But again, like she said about motor neuron disease, people's history is frequently inaccurate,
Yeah.
frequently.
Yeah. Yeah, I mean, I think you have to think of other things that may be unmasked by something. I think this doesn't have any short units. I think to have
Right.
abnormalities in all distal muscles and nothing proximally,
Okay.
usually, so.
You win.
Yeah,
Yeah,
yeah.
I just-
Unilateral, it's not. How about that? Okay.
I think it's just worth thinking
Yeah,
about
yeah,
in the
absolutely.
lab, like, okay, why is this not ALS? Why is this not IBM?
I'll throw something out there similarly, because this is what the interpretation, I didn't initially do this study. The interpretation of this EMG was this could be consistent with multifocal motor neuropathy with conduction block, or multifocal motor neuropathy.
Without
Where's the
conduction block.
conduction block?
There was no conduction block, but it was it was a vague interpretation by a colleague, and it
But that's
was.
okay.
It was multifocal motor neuropathy, or possibly consistent with it because multiple nerves were affected.
Right.
So what do you think about that? Is that a possibility?
Mononeuritis multiplex in one arm without pain.
Well, I mean, I think if you're thinking that, I would use multifocal motor neuropathy.
Okay,
Mononeuritis
sorry.
multiplex as a syndrome, I think,
Okay.
typically affects motor and sensory. But again, I was bothered by that because of a couple things. One is, yes, they fit into certain nerve distributions, but getting back to the extensor weakness, it wasn't pure involvement equally of radial muscles that bothered me to say this is a radial neuropathy. And it came on so quickly, and it affected multiple nerves within a week, which I've never seen that in MMN. I don't know. Have you ever seen that? That in a week, multiple nerves come on that quickly?
Not that I can remember.
Yeah.
The other thing, apart from the lack of pain for it bothers me that this is still profusely fibrillating a year after the onset.
Yeah.
This is still an active process.
Yeah. So good point. The point was it's bothering Dr. Bland that there's still a lot of fibrillations after a year, suggesting even though she's feeling a little better, there's still an ongoing process going on. I mean, you can have fibrillations that never go away and something that's really denervated, that doesn't fully reinnervate, but yeah, that is bothersome. So what should we do? The other arm, okay. How about an MRI? You said an MRI. Who would do an MRI in this patient? Probably most.
I'd offer it to them.
You'd offer it. So here's the MRI. So centrally, there was nothing abnormal, but this is hard to see, but there was degenerative changes at multiple levels, most severe, and this is just one cut, at the C6-7 level. By severe on the affected side, you can kind of get a glimpse of that here, at the C6-7 level. That's what I was thinking, with sirens going off in my mind. What the heck? What do you do with that? The other levels were mild. There wasn't anything real abnormal.
I think you gotta do the plexus now, because you don't have an explanation for her most weak muscles.
Okay. Okay.
You might have found an explanation for maybe why her triceps is a little weak, right? Had some stuff.
Had some-
but not explained
Yeah.
anything visible.
So her plexus was normal. Check the other side in terms of what, doing needle or, yeah. I mean, you could, but let's say the other side, the same muscles show mild changes, similar but not as bad, or subtle changes. You have these changes on the spine at several levels. So I suppose in my mind, maybe there could be some root involvement on the other side, but I think this is a hard situation. I don't know what to do with this. This is what I was struggling with. Could be early motor neuron, but again, just going back to the history, she was perfectly fine swimming, and then boom, within a week, she pulls herself up, she notes some weakness, so it was really quick. Yeah.
She's a year out now, so if it's MND, she should be getting worse
Yeah, exactly.
in other
Right.
places too.
And you
Unless
might
it's
expect her to,
monomelic.
Pardon?
Unless it's
Unless
monomelic
right.
hemiatrophy.
yeah,
So do
yeah.
you want to call this Hirayama's disease?
No, but
Yeah, what would you have to do to diagnose Hirayama in this case? Because that's a good point. That typically affects the C7 to T1.
Yeah.
Yeah.
I mean, this could be, you know, you do the MRI of the neck, and then you hem and haw and have them do flexion extension and say,
Yeah.
I don't know.
So you would have to have her flex and do that and look for forward compression and displacement and engorgement of the posterior venous dura there.
Have you guys done that?
Yeah.
Flexion
Yeah.
MRIs?
Yeah.
I've never done them.
Yeah, I'm going to show a case of that in the upper arm weakness session in a couple days.
Nice.
So, but how often would you see a Hirayama in an 83-year-old woman?
It's not
Because it's
How often
too-
you see a Hariyama, period?
It's rare, yeah, it's rare, but it's usually younger men, not always, but it's usually younger, you know, in 20s or even teens I've seen patients. So it just doesn't quite fit, yeah. I think the struggle here is, could this finding actually explain the findings? In our minds, it's a level off, right, or 2 levels off.
Yeah.
But could this explain it?
I think it's very unlikely. I'm not saying it's impossible. And then.
And what
if
do you
you're
do?
gonna
Would
s-
you?
Huh?
Oh, go ahead.
I think if you're looking at root-let issues, I think our ability to correlate foramen abnormalities and roots that are abnormal on EMG is not very good. They're off by 1 or 2 levels, I think, a lot. The surgeons that I talk to, they say when they go in there, they will see osteophytes and stuff in the central canal that's getting the rootlets. And then where the anterior horn cells are in the spinal cord is a little higher than through the foramen. So my understanding is the anterior horn cells come out anteriorly, they might drop a level, so that, in fact, if that spinal cord is getting dinged, the anterior horn cells, like Hirayama, could be a little bit lower.
Yeah.
Now, so,
But I don't know that the spinal cord is. I mean,
No, it
the
doesn't
spinal
look
cord,
like it.
it's really the foramen that's narrowed there.
no.
Yeah.
I would just say,
That
this
gets
does
to
not
the
easily explain
the
it to
point
me.
about the prefix plexus. Maybe, you know, prefix and postfix plexus is really root. It's not, it's a misnomer. It's not the plexus, it's just the root contribution to the plexus. So could that explain it?
What about a bad radiologist who didn't actually look all the way down where you asked?
Yeah, I mean, yeah, they didn't go all the way down.
And we don't have the cross-sectional views, so there could be something, even though it doesn't look like it on this sagittal midline, but like there could be something sitting right where you, like a cyst or something in the neural foramen. And this radiologist, I'm surprised it even goes down this far.
Yeah, I mean, you get a
It seems to get stopped in the middle of C7 sometimes.
Yeah, you get the sagittal at 2, 3, 4, 5, 6, 7. You know, you get that. I only have a set picture, but yeah, the axials you don't.
Radiologists didn't comment on each individual level, so it's possible that there is a perfectly good explanation for your findings that just wasn't read on the MRI. So
Yeah.
I think it's a good lesson to look at it yourself.
Yep, absolutely. You always want to look, and you're right. Sometimes, I mean, I think I might have only cut part of this, and not all the detail. I can't remember, but I do believe that there were cuts that were lower down, and I looked at if they didn't comment. But yeah, I mean, sometimes, you know, especially if you're thinking of like a T1 or T2 root issue, that they don't get that far down, and then you have to send it back and say, no, I want this level, and you know. So you hope they read your note and do the appropriate imaging, but they're busy. They don't always do that. So all right. Any other thoughts?
Would you consider also, because I know it's rare, but could this be chronically? And it's so hard sometimes to differentiate, like understanding motor unit potentials, the large and polyphasic, to miss the other ones as normal, really small, and it's a mixed pattern. Would you order a CK at least? Go down the route?
Yeah, I'll repeat it for people to hear. What about still the possibility of a chronic myopathy? So you're aligned with Dr. Anderi, yeah? You know, thinking myopathy.
Yeah.
You know, I think, again, in my mind, and I think it's good to think about all of these weird presentations, but I think the clinically unilateral symptoms, very isolated symptoms, without any clinical weakness objectively on the other side, would be unusual. The absence of any small motor unit potentials would be very unusual. And you're right, in chronic myopathies, like IBM, you're going to often see the large motor unit potentials that overshadow the small ones, so you miss the small ones. But usually, if you pay attention, there'll be short ones or polyphasic ones. So this patient didn't have any of that. So I think putting all of that together, it would be really unusual that this would be a myopathic process. Yeah, but again, you're right. You have to think about those things. Yeah.
I've seen some very odd unilateral arm presentations with lymphomas infiltrating the plexus. So how sure were they that it was normal on the MRI? Because I've seen that missed quite regularly.
I'm sorry, I missed the first part. What's missed?
I've seen some very odd one-arm presentations with lymphomas infiltrating.
Lymphoma.
Lymphoma, yeah, okay. Yeah, lymphoma, infiltrating lymphoma, yeah, when it's infiltrative, it might just sort of pick off fascicles. Is that kind of what you're seeing? Yeah. Well, we're done. No, do you want? I'll give you. I'll give you
What do
more
you
of the
think?
answer. I'll give you. More, I don't know if I have the answer. That's what's fun about this, but there is data. There are some articles, and I'm not going to go through a whole bunch of articles, but I do think it's important to know about these. That there are some papers, small series, small cases, showing situations like this, where you have a spondylitic amyotrophy and you have a discrepancy of where the imaging is, a level up. So this was a case in a clinical journal of 3 cases. They had C8T1 findings, hand amyotrophy, and this you can see this is very severe compression. So I think to your point, Mike, on the anterior horn cell being involved, but it was not at the C8T1 level. It was a little bit higher.
I buy that.
Yeah.
I mean, I think my surgeons tell me that's what they've seen.
Yeah, and then I think this was another paper about a decade ago of exactly this type of situation where there's unexpected neuroimaging in patients that have a C8 radiculopathy. And they looked at their patients in their database of patients that had clinical features that were pretty consistent with the C8 radiculopathy. They had to have sensory loss, they had to have weakness, they had to have EMG findings only in C8 muscles, normal snap, like we've been discussing. And they found a number of patients that did not have any imaging findings of C7 and T1 disease. And some of them had more compression at a higher level. One had a little bit lower. Some of them had an intramedullary lesion. So I think this happens. I think that there's an offset of the imaging. And I think in this patient, that's probably the case. I think that imaging, in my mind, that imaging is probably the cause of her symptoms. And we did look at the plexus, and she didn't have anything abnormal. So I think this is, a unique case, but the imaging doesn't always match, and there's evidence to show that.
So I'm not a neurosurgeon, and I'm guessing no one in this room is, but do you think a neurosurgeon would operate on that 82-year-old woman's neck at C6-7 for this weakness?
That's the question. You're thinking like I am. These are like questions, There's a lot of questions here. What do you do? Now, she was getting better, or she was stabilized, and she wasn't that bothered. And I've been following her, and I offered her, I said, you're still weak. Do you want to be referred? She didn't want to. She was happy. She could close her hand a little more. She was swimming, so she didn't want to. But I don't know the answer to that. I don't know. I thought about this. I don't know that the surgeons know this. And if I sent her to the surgeon, said if she was getting worse, there might be pushback even.
Are you kidding? You're taking an 80-year-old? There's nothing
let's
surgery
say-
can't
let's-
make worse.
Yeah, but if she was 30, same thing.
All right, that's
Yeah.
that's a
Yeah.
shared decision.
Yeah.
Say, if you woke up with a lot of neck pain and your arm weaker, that's what I would say to the patient. What will you think?
Yeah.
If this woman has
know.
pain, I'm in my personal opinion, that's my quality of life issue. But if this is my mom and she doesn't have pain and she can't swim real good at age 80,
What if this was you and you couldn't perform an EMG because you can only perform it right-handed and not left-handed?
Which is not the case,
Which,
but okay.
which is, but if you
If I
had
couldn't
that
do my
functional
job, I
weakness,
would. That's a great question, and I don't know what I would do, but I'd consider it.
yeah.
That's a great question.
But then, and you say, you go to your surgeon and say, I want you to operate, they might say, well, this doesn't make sense, I'm not going to operate. Would you push it and say,
Well,
I
then
don't
I'd pull up
care?
your slides and say, it might get better. I buy what you're saying. I think I've seen similar to this.
Yeah. We had another case similar to this in our
Except they had
lab.
pain, except they had pain.
Yeah, right. And I think, this is where, other questions that we're not going to answer, but I think are important to think about. Can a C8 redic occur acutely? Of course. Can it be painless? Can you have a painless redic? Can you have a painless neuralgic amyotrophy? And I'm bothered by that when there's not pain, but I think the answer is yes. You don't always have to have pain, or patients will minimize the pain.
So in her case, if she was not getting better and she was not happy with where she was, would you consider sending her for maybe steroid PSI,
Yeah.
Ranil, like, whatever?
A Tessie up there? Absolutely.
I wouldn't. This is where we disagree, as always.
Good.
I mean, I think when you if I was convinced, which I am, that stenosis was compressing the nerve, and as Jeremy said, there's active denervation a year later, in my mind, there's still ongoing damage to that nerve. I don't think a shot
Steroids
isn't going to do
Well,
anything.
I'm not sure it would
I think
work.
you have to decompress
I
it.
might offer it to her, but I'm not, I agree with you. It probably won't work.
She'll feel good and won't be able to sleep for the next 2 days, and then she'll be back at, yeah.
Oh, that hurts.
They might, yeah. I don't think there's any harm. I just don't think the long-term outcome of that is going to be beneficial.
Your electrodiagnostic impression, how you wrote that up.
Well, no. So I don't
Trade
have
secrets.
it, but like I said, I didn't do the EMG. So, but what the diagnostic impression was, I saw the patient in clinic after the EMG. The diagnostic the impression was there's evidence of a chronic active neurogenic process that is difficult to localize. I'm paraphrasing this, but appears to involve the median ulnar and radial nerves, or possibly multiple roots. So it was a hedged impression, which I do all the time. We all hedge.
And then when you say could be consistent with neurogenic amyotrophy or polyradiculopathy, like would you put that differential in your report?
Oh, I would.
Yeah, that's a good question.
I
How much do
absolutely
you
would.
put in? Yeah.
So for the evaluation and management part, I would write that in the electrodiagnostic impressions, and then I like to add, I put clinical evaluation and management for the auditors, recommendations. So it gets by all the 8th graders who are auditing my charts, and it says evaluation and management. And then I'll say the etiology of the above is unclear, could be due to cervical radiculopathy. Compression seems unlikely for this. I say NA seems pretty likely. That's what I would have said that day.
Yeah, what would you have said, Aliana?
Gosh, I mean, I think that it's important to be transparent when there's uncertainty, and so I would explicitly state that, include the clinical impression as well, and I would add recommendations for management, because certainly I would be sending this patient to physical therapy, particularly with hand weakness at her age, threatening her independence. I'd want to do a functional evaluation and see what mileage we could get from non-surgical, non-interventional management.
Yeah.
And I might offer her an orthotic to put around her fingers when she's swimming.
Yeah. And I think these are good discussions. I think it depends on your practice, right? So I don't recommend, I don't make recommendations for treatment in our EMG reports. I leave that up to the referring physician. And in my practice, in terms of putting what I think the diagnosis is, varies. So if she had classic pain, horrible pain, the pain goes away after a week, she has weakness, I'm confident this is neuralgic amyotrophy, I absolutely would do the same thing and say this finding, I'd put localization, and this would be consistent with neuralgic amyotrophy. But if I'm not sure, I don't do that. And in this case, if I were writing the report, I would be more convinced that this was more, even without the MRI, that the localization was more likely root, and I probably would have said, still hedged, it can't localize, it appears to be, is neurogenic, appears to be root, but can't exclude Apache plexopathy, and leave it at that. I don't think I would have put neuralgic amyotrophy in the absence of pain here.
And then do you bill it as right arm pain instead of billing it as a ridic?
Yeah, yeah, we won't get into billing, but yeah, I mean, our billing is more
No,
symptom.
that's a great question.
So like out of the private practice, you
Yeah,
Oh, yeah.
So,
yeah.
I'd put 2 or 3 ICD-10 codes, and I'd bill an E&M, for sure. But I told you I would separate out, and then I would say, or I might say, this is difficult to confidently localize, I'm not sure what's causing this. Possibilities include blah, blah, NA, cervical radiculopathy, or other
Yeah.
causes.
Yeah, and I think
would
that's
give a
good. I mean, I think
recommendation for
our job, our job as neuromuscular and electrodiagnostic specialists is to provide the referring physician with as much information that helps that patient, right? That's what we do. That's why we're doing this. So I have no problem, and I have arguments with colleagues in our lab of how much should you put, do you put the diagnosis, if you know the patients are reading your EMG 10 minutes after it's been posted, how much do you put in? And I'm of the mindset, I'm gonna put in what's gonna help that physician in knowing what that patient has. So if I do an EMG and the patient comes for weakness and there's profuse myotonic discharges and I know the patient has myotonic dystrophy, has the clinical features, I'll put that in my report. These findings are not, I might put these findings are not specific, but would be most consistent, or a strong consideration would be blah, blah, blah. And
Highly
I'm comfortable
suggestive
doing
of.
that. Highly suggestive. We know how to wordsmith a bit, but I think some people are cautious about that. They don't want to go out on a limb. And this might be one case where it's hard, we don't really know. So we're a little more cautious of saying what the exact cause is, but at least help them and know it's neurogenic, it's chronic, and the possible localizations. And I don't think there's a right or wrong way of reporting that out. So.
You have quite the collection of hedges here in this case, and you need to add one more and say that this could be an intraspinal process if you didn't have the MRI in hand.
Yeah. If you come to our lab in the EMG lab at Mayo, there's hedges all over the place. Every day we add one, So, yes.
On your chart, you only showed one level of paraspinal capacity, but when you're looking for CA radiculopathy, how low are you going to go anatomically? You go down to T1, T2, keep going if you don't see anything, or where do you go?
Yeah, that's a good question. If I think it's C8 and I'm not finding it at where I think the C8, how many levels do I go below? For the first thing I do is I make sure when I go into the paraspinal, and I'd be interested in what you guys do, is I make sure I'm angling the needle rostrally and caudally to examine a wedge shape. And so I'm trying to get a broad area of the paraspinals. And then I usually just go up 1 or 2, up 1 or below 1.
So you take the needle out of the skin
Yeah,
and put it in,
if
right?
I'm not finding it,
do
I
too.
suspect.
I'll almost always go at least 2 levels.
Yeah.
If it's a lumbar and I'm doing paraspinal mapping, I will do 4. 4 different needle sticks.
Yeah, but if you find it in the first one, do you stop or you keep like if you have an L5 or
If I
DIP?
get to a score of 4 on my first insertion of the needle, I stop. Because there's nothing
Yeah.
that's going to make that
Right.
person normal.
Yeah. What do you do?
Similarly, I would use at least 2 levels in cervical and 3 in the lumbar.
Yeah.
I'm talking more about specifically anatomically, so you're looking for CA.
Yeah, so go
Go
low.
to T1 and you don't see anything, you go down to T2, or?
I go to T2,
Yeah.
or between T1 and T2.
I go
How's
one
that?
level down, and then if I'm really suspicious, it's rare, but if I'm going to do another level, and some of those cases are patients that, they have a big neck, you can't really tell exactly where you are, then I might go down a couple levels. It's not that common in my practice to do that. Yeah.
Would you report this as being electrodiagnostically active radiculopathy, even if the paraspinals were didn't have any denervation there, and then the proximal triceps only had chronic neurogenic changes?
Yeah, that's a good question. So the question is, in your report, would you say this is electrodiagnostically an active, let's say we're assuming it's a radic, is it an active radic? How do you use that term?
I would
What'd
say
you
that
say?
that this is probably an ongoing active process, probably, okay?
So you would hedge.
Of course. Well, how do you know for sure that it's not just such a severe problem that the fibrillations are persisting?
Yeah.
It could be with evidence of incomplete reinnervation. Correct?
You could
Yes.
say that.
Yeah.
That's very, in my mind, very defensible and might be the best answer.
Yeah, I think, what about you?
Yeah, it's a tough call, and I think that's very controversial. You have distal muscles, so they're likely to continue to have increased insertional activity even in the chronic phase. I would use the term active.
Yeah, I think this is that's a great question. And I think I agree. I would use the clinical my clinical judgment too, you know, and I think we have to do that in everything, but, you know, it seems active, but you're right. I mean, this could be severe denervation and just can't reinnervate. And if she said, you know, my symptoms are getting better and better, and I'm getting stronger and stronger, is it really active? Is there still compression? And we don't know. I mean, we know by imaging it looks like that. So that's a tough one. I think if the paraspinal showed 2+ fibs, I would absolutely say active. But triceps didn't have fibs, paraspinals didn't, so it seems like there's reinnervation. And I think the term active is what do people understand when they read that report? And we did a study on that, which is for another day, but we did a study, surveying surgeons and giving a bunch of examples of reports. And, you know, if you say an old process with uncompensated reinnervation, they don't know what that means. So we try to say active or not active, but sometimes we say whether or not it's active or not, we can't determine. Again, I don't think there's any problem hedging, and I would say, you know, it's better to say we don't know. We don't know everything. We can't tell everything on the studies, so we're always constantly learning. Well, I had 2 cases, but I hope that you've enjoyed this. If you enjoyed it, give good recommendations, and if they have this next year, we'll do the second case, which is a fascinating case.
Stay tuned.
But it will take the whole time also. So I hope that you've enjoyed this. The comments are fantastic. Like I said, these are great. I learned so much from listening to all of you, from my colleagues, and I appreciate you coming up here, not knowing what you're going to get, and thank you very much.
Thanks for putting up with me, huh?
Enjoy the rest of the day.